Okay, so we have a variety of people on the line. That's great. I'm going to share my screen and get started, but it is still a relatively small group, so feel free to interrupt at any time. Okay, can everybody see my screen?
Yes, we can.
Yes.
Great, thank you. Okay, so we're going to talk about postpartum hemorrhage today. Postpartum hemorrhage is the leading cause of maternal mortality in Canada, about 13% of deliveries. What that actually means is we have about just under 10 deaths per year from postpartum hemorrhage. So I'm going to jump in with the case. So this is fast FRAN. She has her fingers crossed. Always good to have a positive attitude going into your delivery. So that's great. She is a gravida 3, para 2, with a history of postpartum hemorrhage on her first delivery. RH negative. She's group B negative. So she comes in at 39 and 5 weeks. She ruptured her membranes 35 minutes prior to presenting, and she is now 8 centimeters. She delivers relatively quickly at 7 o'clock in the morning, spontaneous vaginal delivery. Baby's very happy. Apgars are 8, 8, and 9. First degree tear that was repaired by her care provider, who happened to be an MD. She got 10 units of oxytocin IM. And now it's about 45 minutes later. The MD has now left. She was delighted to be able to get to her clinic on time. And Fran calls the nursing desk because she got up to go to the bathroom and there's a big pool of blood on the floor. So this is one of the nurses that works in my facility. Shout out to all the general nurses in rural care. It's a super, super difficult job to be a jack of all trades. And Bryce does an excellent job of it. So, you know, you have a woman who's just delivered a baby, she's bleeding. And so Bryce starts to think about what she knows about postpartum hemorrhage. So, you know, given that a woman can potentially bleed out her entire 5-liter blood volume in 10 minutes, you don't have long to think, although thankfully most women are not bleeding that briskly. So any thoughts, and this can be a rhetorical question, or you can unmute and share your thoughts if you like. But basically, we're just trying to go through a process here of, okay, if this patient was, you know, in my care, what do I want to do next?
We want to check and see if her fundus is firm or not. Has she gone to the bathroom to pee? Is her bladder full? And I would be thinking about, does she have an IV in?
Yeah, great thoughts, great thoughts. So I kind of had in my laundry list similar things. I always like to call for help. And of course, you know, these are things you probably do, but you do them so commonly that you don't even think about them. That's part of kind of unconscious competence, which is great. Get her vitals, yeah, palpate her uterus, start an IV. If you have blood tubing available, it's always good to pull that out because you might need to do a transfusion. Get a CBC, a type and cross. If she's very dizzy, you can put her in Trendelenburg. So put her kind of with her head down and maybe start to get a light and a speculum out. So you do examine her and her fundus is boggy and she's past a grapefruit size clot. Her vital signs, her blood pressure is 108/68, her pulse is 120. And her temperature is 37.1. So with these vitals, you know, this is from the MOREOB slide set. And this is good for emergency as well. This is hypovolemic shock. And the signs and symptoms you see with a mild hemorrhage, which is kind of, you know, a diaphoresis, anxiety, some cool extremities. As they start to move towards losing 40% of their blood volume, they'll get tachycardic and tachypnic. And then as we move into severe shock, they will then get hypotensive. And it's always hard to tell what is hypotension in a young woman. You know, I right now am probably running a blood pressure of about 95/60, as are maybe many people on this call. So, you know, young women tend to, or women of childbearing age tend to have lower blood pressures, but hopefully you have a blood pressure, you know, on the chart from when they came in. And so you have some benchmark for what their normal blood pressure is. And once they start to get hypotensive, agitated, confused, and I find the agitation confusion quite striking. That to me is one sign that kind of starts to get me worried. Then you're moving towards severe shock, which is 40% of your blood volume. Okay, there is also the obstetrical shock index. So that's when you take the heart rate over the systolic blood pressure. And if you have a value greater than 1, it's predictive that this person will need a blood transfusion, ICU admission, and possibly surgical intervention. So that's another marker that you can use to assess, you know, how much trouble you're in, so to speak. Okay, one pearl, and I'll mention it a few times because it's really important. 70% of your postpartum hemorrhage is uterine atony. If that's all you can remember, that's pretty good because you've covered 70% of postpartum bleeds. The other 30% is made up of tissue, trauma, and thrombin. But always start with the uterus and compress the uterus, and 70% of the time, that will get you where you need to be. When we look at risk factors for postpartum hemorrhage, there's 49 of them. If anyone can tell me all 49 risk factors, I'll be super impressed. But I tend not to have 49 risk factors memorized, but I do think of the big ones. So all the, and I don't know if you can see my cursor, but all the risk factors on the left are related to uterine atony. So I tend to remember those. So I have kind of a heads up in my mind whether this person may develop postpartum hemorrhage. So if they have a large uterus, if they've had a rapid labor, been using oxytocin for a long time, for a long induction, or if they have a fever and infection. So those people are at risk for postpartum hemorrhage. And then after uterine atony, you get into your tissue, your other T's, tissue, which is retained placenta, trauma, and thrombin. So if you can remember uterine atony, tissue, trauma, thrombin, those are your 4 T's that will help you try and figure out if this person might be at risk for postpartum hemorrhage. Okay, so getting back to FRAN, we call for help, start an IV, type and cross, hang some oxytocin, massage the uterus, and then other stuff. So when I say other stuff, usually what that means is we want to go for our postpartum hemorrhage boat. And for 15 years, we kept our postpartum hemorrhage boat in a little linen closet with all our other supplies. And the last time I went there, I couldn't find it. You can see, you know, we've got the eye gel, we've got all our other supplies, but where the postpartum hemorrhage boat was, there was this, someone had kindly placed this little sign saying, if you're looking for the postpartum hemorrhage boat, then, you know, look behind you because it's not here anymore. So I do have some advice for people who lose things often, because I'm one of those people. And my advice would be when you eventually find the thing that you have lost, don't put it back where it belongs. put it back where you first went to look for it, which may be the same place as where it belongs, but I find that helpful. And I was a little bit disappointed to go looking for my postpartum hemorrhage boat and find that it wasn't there. So, you know, I did go across the hall where I was told it was. And then, you know, someone had taken the time to make these various boats and put them in this cart. So the cart's on wheels, but it's quite large and it's a little bit bulky. So it's kind of more like a Titanic than a boat. And when you're making your boat, I think it's helpful, you know, to just use a Rubbermaid and something that you can go and grab with two hands and run with it. Because, you know, getting a big bulky cart, even if it's on wheels, and then you've got all this other stuff. You've got your eclampsia boat, and then there's another boat that's a third drawer. You want something that's light and nimble. And so when I looked in the drawer that was the postpartum hemorrhage boat, you know, there were 7 pairs of ring forceps and 2 weighted speculums and, you know, 7 IV sets. So really it would be helpful to get your team together and decide, you know, what it is you really need and just have that in the boat. You don't really want kind of a catch-all, you know, boat that is going to be difficult to find what you need. And I appreciate, you know, in our facility, you know, we have 40 people who all do maternity, you know, half time. So you want a group of about 5 or 6 that really love to do maternity to design your boat. Sorry, I've got both kids still at home today, so you might hear them in the background. So, you know, I looked in my postpartum boat and yeah, I kind of felt like this, you know, I was swimming in all this material and I couldn't find exactly what I wanted. So keep your boat nice and small and only have those things in them there that you're going to need. What I do like about our system is we have all our meds in a small container and they're all there. So, you know, you have your misoprostol and your ergonovine. The Hemabate needs to be in the fridge. So we keep this tiny little boat in the fridge. And I think that's a good system. So all your meds are right there. And we have a little instruction sheet on how to give them. So keeping your meds separately in the fridge in a tiny little boat, I think works well. Okay, so I stole this slide from the lovely Andrew Kataska. I don't know if you've gone to any of his lectures, but he likes to talk about the golden 10 minutes. So first you want to get help. Second, start a large IV. If you've got blood tubing, pull that out. And then, you know, normal saline and just run it wide open. Or if you like Ringer's lactate, you can do that too. And then, you know, because most of the time, 70% of the time you're dealing with uterine atony, you really want to compress that uterus. And, you know, one hand on top, one hand on the bottom, and, you know, provide some really good pressure there. And that will solve most postpartum hemorrhages. As was previously mentioned, you want to put in a Foley catheter if they have a large bladder that can, you know, cause the uterus to continue bleeding. And then what I like to do is a shotgun approach. So it's not like NRP where you do one thing and you wait 30 seconds and then you do another intervention and wait 30 seconds and see if that works. Just start everything at the same time. So get your oxytocin going, you know, give some misoprostol. And if you're going to give that misoprostol, you want to give it sublingual. So PO will work, but very slowly. So make sure it's sublingual. And then it gets absorbed through the mucosa. And you avoid that, what we call that first pass, where it kind of goes through the liver and it takes time to get into the system. You want it absorbed right through the mucosa. So give it sublingual. You can also give it rectally at the same time if you like. Hemabate, which acts the same way as misoprostol, but you can pull that out of the fridge. ergot can be given IM, and then tranexamic acid can also be very helpful. If they're in that, 20 to 40%, moving towards 40%, get your lab to type and cross match quickly and start transfusing blood sooner rather than later. So 2 liters of normal saline or 2 liters of ringers, and then you should be moving on to blood for sure. If none of that seems to be working, then you got to move to your other T's. So you've got to think of, tissue. Do you have a retained placenta? Trauma? Do you have a cervical laceration? In which case you're going to have a good look. Or, does this person have a bleeding diathesis? So here's all your medications. Misoprostol, we just mentioned, give it sublingual. Tranexamic acid, which is an antifibrinolytic, we use it in the emergency room as well. 1 gram IV is your dose. You want to be hanging oxytocin. I just put 40 liters in a bag and run it wide open. Ergot is 0.25 milligrams, and you can give it IM or IV. But the side effects are less with IM. So I try and go IM before I go IV. Watch out if you're pushing oxytocin because that can also drop the pressure. So if you're giving oxytocin, it's best to, I think, put it in the bag and run it wide open rather than push, 3, 4, 5 units IV because you're going to run into side effects. Okay, so feel free to ask questions, or if I've been chatting too fast, let me know.
I'm just wondering, I know right now here in Island Health, we're having a shortage of oxytocin. I'm not sure if that's a provincial issue that's happening with oxytocin supplies. So we're still using oxytocin as active management in PPH, but for the expectant management, we've gone to carbetocin now just to save that oxytocin for hemorrhage. I'm not sure what's happening elsewhere in the province.
I was not aware of that. So I'm in interior health over in Fernie. So either I'm just not aware or it might not be an issue in our health authority.
Yeah.
You would think it would be provincial though.
You would think so, yeah.
Yeah, so you're using carbetocin.
For expectant management, and then saving our syntocin because the shortage is island wide. So we're saving our oxytocin for actual PPH issues that need, yeah. And for inductions, yeah.
The carbetocin you're giving IM as you would?
Yes, yeah, we have directions. We had to upgrade our monograph through pharmacy with Island Health so that it's being given IM after the cord's clamped for the expectant management piece, but it can be given IV or IM. Mm-hmm.
Right. Okay, well, thanks for sharing that.
Yeah.
It is significantly more expensive, of course, than oxytocin, but
I know, but there's a shortage. So gosh, so it sounds like it might just be us then here in Island Health that are dealing with this.
Possibly. Anybody else on the call received notice to save your oxytocin?
Well, that's a good sign. Maybe it'll get straightened out faster for us then.
Makes me wonder, are they the same company making both things?
I wonder, yeah.
Okay, so moving on, once again, 70% of postpartum hemorrhage is tone. So don't forget about that. You do not want to massage the uterus prior to delivery of the placenta, so do make sure the placenta has been delivered. And then talking about the placenta, I wanted to mention a few things. So I guess in People magazine, they put a recipe for placenta polenta. And I thought I would share, even though, it might be getting close to lunch for some people, I hadn't seen that before, so I thought I would share that with you. So the three things I wanted to talk about the placenta is there is an increased risk of postpartum hemorrhage if the placenta does not deliver within 15 minutes. 90% of deliveries do deliver their placenta within 15 minutes. But your postpartum hemorrhage rate jumps up to about 13%. So, you know, if you're having trouble, that placenta is not coming, you're trying a little bit of manual traction and it doesn't seem to be coming, then you might want to think about IV access at that time and postpartum hemorrhage if you're having trouble getting the placenta delivered within, you know, 10 to 15 minutes. Placental cord drainage does decrease hemorrhage and hastens the delivery of the placenta by about 4 minutes. And I had always done this, and I think it was just because I was taught to do that. So I, you know, once I have my blood glasses, I do just kind of drain the cord, but I wasn't aware of the advantages, but there are some advantages in decreasing hemorrhage and hastening delivery of the placenta. And then the final thing I wanted to mention, which I haven't had great success, but I'm interested to know from others who have been practicing a long time whether they have had success, is the mesoprostol slurry. So you take 800 micrograms in 30 cc's of normal saline. So you put your mesoprostol in that little silver dish or whatever that you get, and you put 30 cc's of normal saline, and you kind of swish it around and make this slurry. And then you thread a size 10 NG tube into the umbilical vein, and you keep threading it until it kind of, you feel resistance, and then you pull back, and then you push your mesoprostol slurry into the umbilical vein. And this apparently works sometimes to help the placenta separate and to deliver the placenta. I've only tried it a few times and didn't have great success, but some people swear by it, I think. And then cord traction. Cord traction does reduce the incidence of retained placenta, but it doesn't decrease your risk of postpartum hemorrhage. So, you know, you can pull on the cord a little bit and it will help with retained placenta, but not necessarily with postpartum hemorrhage. Certainly in your multips, I always keep a hand right above the symphysis pubis. You don't want to cause uterine inversion with your cord traction. So just make sure that you're supporting the uterus, the uterine fundus as you're applying cord traction. And you don't want to pull too hard either. I think all of us at one point in our life, we have a cord that ruptures when we're pulling on it. So I'm pretty gentle with my cord traction. The other thing I'm looking out for when I have a postpartum hemorrhage is, are they clotting? So once I have a postpartum hemorrhage, you know, I deliver babies however moms want to deliver, all fours, squatting. One lady delivered under the bed. However they're comfortable is fine. But once somebody's bleeding, I think you need to get them into a position where you can manage everything appropriately. So, you know, you're going to need an IV. I usually get them in a semi-Fowler's at that point on the bed. And, you know, you have that little bucket when you take the bed apart, there's that little kind of bucket or garbage there. And so I'm watching the blood kind of pool in there. And I'm watching to see if there's clots, because if there's clots, then they don't have a bleeding diaphysis. So I can take that off the table. So if I'm covering for tone and I'm seeing clots and I'm like, okay, I've covered 2 of my T's. Now I have to look for either, you know, a laceration or a retained placenta. And so then I'm going back and I'm looking at my placenta and making sure it looks normal, or are there pieces missing? So that's one clue to try and figure out, you know, what is the cause of this postpartum hemorrhage? And looking at the blood that's pooling and seeing if it clots can be helpful. Okay, so what happened to Fran? So 800 cc's of clots were removed. Her uterus became firm. Her vitals normalized. Blood pressure 136/66. Her pulse came down to 110. She continued getting normal saline with 40 units of oxytocin. She got some ergot, IM, a little bit of misoprostol, and they did not have to give blood. So I think that's usually how kind of it rolls. Usually you can stop your bleeding with just massage or your medications. If you've done the new alarm course, there's a couple of additions that they talk about in developing countries. They do have this non-pneumatic anti-shock garment that they're using. It kind of reminds me of masked pants, though. I don't know if you've been around in the early 90s. We were using these masked pants in trauma. And then it turned out that it increases mortality, so you don't see them anymore. So I'm not quite sure about this one, but it seems to be helpful in some countries. It is seemingly to reduce mortality. And if you're really desperate, you can kind of do your own manual compression shock therapy. And so that is when you place your left hand right over the aorta. And there was only one study cited for this technique. So I actually went and looked it up. And so what they're doing is they're putting their left hand like right over the aorta, and then they're putting their right hand over their left hand. So it's almost like CPR, and they're pressing really hard for 5 minutes. And then they swap out providers. So it's just like CPR in terms of you make sure that you apply, firm compression, and that, if someone's getting tired, that you swap out. So this study came from Egypt, and they went from having a mortality from postpartum hemorrhage of 85 per 100,000 to 0, which is really impressive. Now the Canadian mortality rate is 1.4 per 100,000, and theirs was 85. So, they were losing a lot more women to postpartum hemorrhage than we do in Canada. But they found that this technique reduced it to 0. So, if I were desperate, I was waiting for my OR, I tried everything, I would probably try this. But you do have to remember, if you're doing it well, you're cutting off blood supply to the legs. So, I would stop every once in a while and check my distal pulses. But, something to think about if you're all alone and you're a little bit desperate, I would definitely give it a try. The other problem with this paper is they diagnosed PPH as vaginal blood loss that was deemed excessive after delivery, as well as hypotension. So they're looking at women who have like 40% blood loss volume. Okay, so this is my final slide. I always have to end the talk with a cute slide. And don't forget that 70% of postpartum hemorrhage is uterine atony. Okay, so I'm going to stop sharing my screen at this point, and I will take any questions. Oh, I can't monitor the chat when I'm screen sharing, so I'm going to look at that right now. Yeah, so people have shared their different PPH votes, and that's great. Yeah, you just got to make sure it works for your team. So a trolley on wheels, but it's not very big. So that's great. Question about bimanual massage. So I did have that photo there. So you want to compress the uterus from the top and the bottom. And, you know, sometimes I see people kind of poking at the uterus. So you don't want to do that. You want to, you know, get your hand like right over the uterus and really compress it. You don't want to kind of like poke around there. Like, you know, postpartum, you can, even a boggy uterus, you can kind of feel it and get your hand right over it. And then, you know, unfortunately, even though it's uncomfortable, and we all know it's uncomfortable, like we've all had patients go, what you're doing is really uncomfortable. But if you're worried that they're going to bleed out to death, sometimes you got to do it. And if you're able, you know, to give a little bit of fentanyl, if it's really terrible, then that's okay too. But you've got to compress that uterus. I don't know what nursing scope of practice is, but you know, you need to put that hand on the inside as well and really sandwich it in. You know, the picture I showed was a fist. That seems a little aggressive. I don't do that. I feel like I can get good compression, like with my 2 fingers and my other hand, like just really, you know, compressing it this way. A fist seems overly aggressive. If you have very small hands, I think that would work. I don't, they're pretty big. So, you know, 2 fingers is how I would go. Anybody on the line can help me with nursing scope of practice? Are you able to do this? Or certainly they do the top part, because I have my nursing colleagues help me with that, but.
I think I might just kind of connect with our registration body just to make sure that we're kind of clear on what our scope is. And it'd be just kind of good to know ahead of time.
You know, if you're all alone and you don't have the primary care provider, you know, I don't think you can be faulted for saving a life.
No,
so
exactly.
I would get in there and
yeah. Yeah. One thing I was going to make a comment on our med trolley that we take in, it's we always put it beside the nurse that's in charge of the mom. So it's always there ready for that nurse that's looking after doing the medications and stuff. So she's supporting that part of the delivery. But to help with we made a quick reference. So where all our meds are stored, the uterotonics, we also have like a quick 1-page quick reference how, you know, like remembering about who, you know, caution with blood pressure and who's asthmatic, like, and how to give, and, you know, how to give it slowly. What are the parameters? How often do you have to do the vitals? And so that the nurses don't have to go to IV monographs to look it up in an emergency. It's just all there ready to just refer to right away as you're giving it. So the nurses, especially the new ones, are really finding that helpful.
Yeah, we have that same thing. So I showed that picture of the small med boat. Yeah, so in there we have a cheat sheet, and you're right.
Yeah.
What you want is like dose, route, side effects.
Yeah.
And that can be really helpful. Someone was interested in the heart rate over systolic blood pressure equation. So that is the obstetrical shock index, or if you're in emerge, it's called the emergency shock index. It's all the same. I will just maybe share my screen and go back to that slide. Okay, so obstetrical shock index, heart rate over systolic blood pressure. And if the value is greater than 1, so if your heart rate is 120 and your systolic blood pressure is 120, that's 1. That's pretty good, not too bad. You know, once you're heart rate starts to go above 120 and your systolic blood pressure is going below 120, now you're getting to a value that's greater than 1. So I find it easy to remember. One's pretty easy to remember. Then you just have to remember the heart rate over systolic blood pressure, and that's the obstetrical shock index. You know, so if you're doing all your stuff and you know, you can quickly calculate, okay, well, their heart rate's 120, their systolic blood pressure is 90. Okay, so, you know, they've got a value greater than 1. It's like, okay, well, we better get moving here. This woman's in trouble. So it's just another like data point, I guess, that you can use to help you assess, you know, how fast do we need to move here? So hopefully that.
So sorry, are you taking the heart rate and dividing it by the top
Systolic blood pressure.
That's what you're doing. Okay.
Yeah, so heart rate over systolic blood pressure. And if you do the new alarm course, they have it in there as well. Okay, if there's no more questions, then yeah, Rebecca, I'll leave it.
Thanks, Virginia. That was great. I think everyone found that really helpful. I thought I'd take this opportunity as well. Since this is a MaBAL drop-in session, you guys might know that MaBAL is the Maternity and Babies Advice Line. And so that's part of the RTVS program. There are a number of different pathways you can call, including MaBAL. And everyone who answers the phone at MaBAL is lovely. So you never need to worry about whether they'll want to talk to you, because they will. We've also got Rudy, the emergency line, and Charlie for any pediatric. So if you are delivering a baby and the baby is in trouble, you might be talking to MaBAL and Charlie on the same day, potentially. Yeah, and there's also some quick reply pathways. I don't know if anyone ever has to worry about dermatology or hematology here, but they're available as well through RTVS. So if you don't know how to connect with RTVS, this poster tells you how. I will put my email, well, I'll put a website into the chat, and then if you guys want to know more, you can give it a click. Thank you.
Yeah, thanks for sharing. And I will say I use the dermatology quite a lot in Emerge. And it's nice to get someone right away. You know, there is the race line, but they don't necessarily get back right away. So if you wanted, you know, whatever newborn rash that looks a little bit funky to you, you can try the dermatology pathway, and they're very responsive. I would recommend that line. And the other thing I wanted to mention about the RTVS pathways is it really is a phone a friend feature. So, you know, when I'm in Fernie and I have a delivery and I'm all alone and it's 3 o'clock in the morning, I will call MaBAL just for a second opinion, just for someone to talk to. Of course, I have my own colleagues that I can call, and sometimes I will. But sometimes, you know, they've been up with a delivery and I don't want to call them in at 3 o'clock in the morning. So it's not a hierarchical, like, call, you know, someone who knows more type of thing. It's more like, if you'd like to run the case by someone, or you just need a hand, that's what we're there to provide. And often when I'm on Rudy or MaBAL, I'm just calling PTN, like I'm sitting on the phone because you've got better things to do. So please, like, reach out to us if we can be of help, because that's what the service is all about. It's helping rural providers who don't have a lot of people on the ground.
Who all are members of, like, who are the healthcare providers on the other end? Like, if we were to call, is it just, can anybody be a part of that, or how does that work?
Yeah, so the MaBAL team came together. I mean, Jeanette Boyd was our lead. I don't know if you know Jeanette, she's in Nelson. And so, you know, it was really, you know, providers who have, they're family doctors, all are family doctors who provide maternity care. So you're not calling an obstetrician. Some people feel like they're calling an OBGYN, you're not. MaBAL is family docs who have done maternity care for, you know, a period of time and have a fair bit of experience. And then, you know, who are interested in providing that kind of support. And what I mean by that kind of support, I mean someone who, when you call them, is going to say, how can I help you? Not, why did you call me? So we're trying to get away from that culture of, why did you call me? I'm kind of busy, to, I'm here to help. How can I help you? And so, you know, physicians, you know, we're kind of handpicked by our lead, really. But if you know someone who would, you think, you know, like to be a MaBAL doctor, then certainly you can email me and I can put you in touch with our new lead.
How is the MaBAL and Charlie, all these, are they supported provincially? Like, how is it funded?
Yeah, so they're all funded a little bit differently. But RCCBC, in conversation with the Ministry of Health, funds the different pathways.
And is it like it's like going on like long term? It doesn't have like a period of like 3 years, 5 years, and then it stops. Like,
well, the hope is it's
ongoing?
long term. As you know,
Okay.
every program that requires Ministry of Health funding is always potentially on the chopping block. But yeah, the hope is it's ongoing. We've had lots of great feedback from new providers, international medical graduates who find themselves, you know, alone in small communities, have really appreciated the service. So we're hoping we can continue with it.
And how many doctors are currently on the MaBAL like roster that help kind of give this support? Is it quite a few, or is
20, 15, 20? I don't know. Rebecca, do you know?
Yeah, I think it's something like 20, and there's some midwives as well that haven't come fully on board to answer the call yet, but they certainly do a lot of outreach and education with MaBAL as well. And in terms of Rudy, I think we have a few more. Maybe we have 40. Charlie, there's not as many, maybe 15. I'm kind of ballparking a guess, but the idea is it is available 24/7 though. So there's never a time where you'll call. Well, hopefully there's never a time where you'll call where someone won't answer. So that's part of the program.
I can say firsthand that we've used Charlie, and what a huge support this has been. Like, it's made a huge difference for us for that one case that we had, that we needed that support when we didn't have a pediatrician on available that day. And it was just fabulous support that we got through this program. Thank you.
Yeah, great to hear. And the other thing is, you know, if you call with I don't know if all centers have an iPad, but you know, we can actually see the patient, and that can be really helpful as well.
Yes, we got an iPad through the Arson support, and yeah, we were able to bring the iPad and that pediatrician on the other, or that support from Charlie right up to the baby, so they could help, you know, see the baby in real time. It was really useful.
And if you have a telehealth cart as well, we can call in the telehealth cart from the iPad, and then we can actually move the camera on the telehealth cart so we can zoom in and zoom out. So for newborns, that's really, you know, we can get a good look, shall we say, and that can be really helpful. So my apologies to anyone who didn't have the opportunity to introduce yourselves, but if you know, some people like to do that, some people kind of hope they don't have to. So if you would, we're very much interested in where you're calling from and who's on the line, but if you'd rather not, that's fine too. We have a few minutes here before our hour is up. When I practice these sessions, I try and make them about, 40 minutes. And then, on the day when I go live, I tend to race through them in about 25 minutes. So it's always a little bit shorter than what I originally intended.
I noticed IDH staff, sorry, I forgot the name of the woman who was on that Zoom window, wondered if it was being recorded. It is being recorded. Normally what we do is we do upload the recording to YouTube, and then it's linked to from the MaBAL page on the RCCBC website. If you really don't want your face, anyone who was on camera when they spoke, maybe in that video. So just let me know. I can edit you out. It may kind of be a bit of a funny break, but if you are concerned about that, please let me know. Glenda, I think you spoke on camera, for example. Okay, that seems like you're fine with that. Okay.
And then I forgot to mention, Isabel had mentioned about cord drainage is not recommended if the cord is intact to the neonate. And yes, that would be true. So I'm talking about after the cord has been clamped, yeah. And Rebecca, do we have any coming up?
We do not have any more sessions scheduled, but I'm very interested in getting some more scheduled. I know the MaBAL midwives are keen to be starting some of their own sort of coaching sessions, but I don't have all the details on that because they haven't been firmed up. So if whoever you heard about this session from, hopefully it was Tom from Arson or Virginia, you can connect with us, or I've put my email in there. Let me know if you're interested in hearing more about those, and then I will put you on our mailing list.
Fantastic. Okay, well, I think we're going to end it off here. Enjoy your weekend. And if you're celebrating Christmas in the near future here, best wishes with regards to that as well. Oh,
Thanks,
one
Virginia.
minute.